So it'll be Dr. Manasiev on standardized protocol for the treatment of complex aortic aneurysms.
Hello. Hi. I'm here to represent the standardized approach for fourth fenestration physician-modified endograft to treat complex abdominal aortic aneurysms. What is complex abdominal aneurysm? They are defined as aneurysm with a proximal infrarenal neck not anatomically suitable for a standard EVAR. These include short neck infrarenal aneurysm, juxta and pararenal abdominal aneurysms, and thoracoabdominal aneurysms type 4. The complex endovascular solution is, with the incorporation of renal and visceral arteries, is required in these cases when the patient is deemed to be at high risk for open surgery. This is our endovascular options. Custom-made devices, excellent early and long-term outcomes, but can be used only in elective cases because of the manufacturing and shipping time up to 3 months and the high price. Off-the-shelf devices, immediately available and represent a valuable option in urgent or emergent settings, but their applicability is limited by anatomical constraints. Also, the spinal cord ischemia rate for juxta and pararenal aneurysms repair using off-the-shelf devices has been estimated up to 10%. Other urgent endovascular alternatives are chimney and in situ fenestrations, where gutter endoleak type 1 and target vessel instability may cause a concern. PMEC, physician-modified endograft, represent a valid therapeutic option. PMEC allows rapid on-table customization of a standard abdominal or thoracic endograft, devices with the creation of fenestrations, scallops, or branches based on the aneurysm anatomical extent and target vessel position. We describe our initial experience of the safety and feasibility of the standardized approach with the PMEC based on specific anatomical selection criteria, measurement method, and a standard technique of modification using Valiant Captivia thoracic endograft. We attend in the SPHERE study, the standardized physician-modified fourth fenestrations endograft registry, which is a multi-center observational cohort registry. This registry was initiated in October 2023 and collects data from 13 vascular surgery centers, 11 Italian, 1 Spanish, and 1 Bulgarian. The anatomical suitability for PMECs indication abdominal aneurysm above 6 centimeters with high risk of rupture, abdominal aneurysms above 7 centimeters, symptomatic cases, urgent and emergency presentations. The exclusion criteria is patient with hemodynamic instability, patient in the hemorrhagic shock, and the age under 50 years. Preoperative planning and graft preparation take measurements of the vertical and lateral position of target vessel, transfer of measurements onto a technical drawing, which takes 30-40 minutes for this preparation, and we can go to the main event. Graft modification technique. We fully deploy graft Valiant Captivia without the free flow segment, marking of the anterior zero axis using a vertical reference line. We modificate one of the 8 markers. We modificate them as an S marker to making the anterior zero axis. The fenestrations. This is the fenestrations. They are made with the ophthalmologic cautery. It's 6 to 6 millimeters to renal arteries and 8 to 8 millimeters to superior mesenteric artery and celiac trunk. This is the modification of the 8 marker to S marker, which define the center line and the antero-posterior position of the endograft. This is the reinforcement of the fenestrations with the tip of the V18 guide wire, reinforced with a non-adsorbable suture. For this case, we make this with preloaded guide wire for the superior mesenteric artery and the left renal. This was our first case. This is the ready graft, and this is the S marker. This is the constraining wire. It's reduce the diameter of the graft up to 20 to 30%, and we can partial rotation when we deploy the endograft in the human body. This is the resheet of the endograft to the delivery systems with a vessel loop. We have to warn for the malrotation of the fenestrations. Implantation and finalization. We verificate the S marker for correct anteroposterior orientation outside the body, introduced through femoral access under fusion imaging guidance. During partial deployment, rotational adjustment possible using the reducing type fenestration alignment, full deployment followed by cannulation of the fenestrations, and release the free flow. Implantation of bridging stents through the fenestrations, and complete finalization with the distal EVAR to achieve a complete aneurysm exclusion. This is our patient cohort. Total patients of 4 aneurysms, type 2 juxtarenal, 2 pararenal, 60 vessels treated with fenestrations. All presentations was early urgent patients. This is the result for the study. They were made 50 AAA for 13 centers. Overall technical success was 96%. The 30-day mortality rate was 0%. No graft-related type 1 endoleak. And implantation geometric analysis shows 100% integrity. This is our case number 1, male patient with juxtarenal abdominal aortic aneurysm with left femoral amputation. This is the aneurysm. This is the cannulation of the right renal artery, left renal, and the superior mesenteric artery. This is the right kidney. The mesenteric superior. And this is the final result, and with orthounilac EVAR and a patent internal iliac artery. The representative case 2, also male patient infrarenal saccular aneurysm with short neck. This is the result. This is 30 days after the procedure, post-operative CT. Here we have an endoleak. We thought that this is endoleak type 1, but when we continue to procedure, we understand that this is type 3C. From the right renal artery, there was a gap between the stent, the bridging stent, and the fenestration. We cannulated the stent and make a PTA, a balloon dilatation. This is the final result. This is after 1 month. The third case, also a big aneurysm, proximal neck length 3 millimeters below the renal arteries. This is the arteries. Here, when we cannulate and implant the renal artery, the stent removes from the balloon and falls into the renal artery. We cannulate it from a brachial access with a second guide wire. We put it back with a snare, and we stand with, we smash it with another stent. This is the post-procedure picture. This is the post-procedure CT. The stent is, you can see it. In a conclusion, this is the first multi-center experience reporting the real-life outcomes of the treatment of very large and urgent AAAs using 4 fenestrations PMEC. This modified endograft implanted in fragile patients with high comorbidity rates show excellent technical implantation, safety, and efficacy, as well as early outcomes. Longer-term follow-up and larger cohort studies are needed to better define the clinical role of this standardized approach of PMEC. Thank you.
Thank you, Dr. Manasiev. Very interesting. Congratulations. Very interesting cases and very well done.
Thank you.
Some comments, questions? Are you performing by yourselves, or you need a proctor for the fenestration itself?
We have a proctor for the first case, Dr. Michele Piazza from Padua, from the University of Padua, and that was one
Fast
case.
learners.
Yes. Yeah.
Very good. In case no other questions, thank you very much once
Thank you.
again. And I will ask now Dr. Cesna to speak about melody valve implantation on pulmonary position. And after that, you are going to take a look to see. Is it possible to change, момчета? Значи разменяме сегашната презентация с следващата. Просто правиме switch. Yeah, we are going to see after that the melody valve live implantation with his proctorship in our cath lab. So
All right.
excellent. Thank you.
Hi, everybody. Thank you for the invitation to give this a very short talk about a very big topic. And I will go through this pulmonary valve implantation in a very brief timing. So let's start from the beginning. I think that for my colleagues, I have the impression that they imagine that the interventional cardiologist is like a royal family member and having a dinner and having fun every single day. However, at the end of the day, we look a bit like that. That's not real image, hopefully. But at the end of the day, we have lots of materials and lots of things in our cath lab happening. As a congenital interventionalist, we do not have any specific devices for our interventions, so we have to be very creative. So, and Melody Valve is one of the devices that is dedicated only for the congenital heart disease treatment. So basically, I will go through these topics through my presentation. And basically, we're treating percutaneous pulmonary valve implantation is mainly dedicated for RVOT dysfunction. So either it's operated by surgeons because of tetralogy of Fallot, which is one of the main indications. Either it's repair with flap or bioprosthesis or Contegra. But at the end of the day, we are dealing with a stenotic pulmonary valve. And regarding the indications, we have some criteria. Either it's moderate or severe regurgitation or severe stenosis, which mainly is more than 2/3 of the systemic pressure in the right ventricle. In a clinical scenario, the patients may have exercise intolerance, dyspnea, progressive RV dilatation and dysfunction, and some arrhythmias, mainly is ventricular arrhythmias. And we have to have a good anatomical criteria with suitable dimensions of this pulmonary artery and suitable landing zone. So in my institution, we have several options to treat these patients. We start with the first one. So the first one is the Melody Valve, which is one of the smallest, but one of the most often used. And this may cover the anatomy up to 22 millimeters. And the rest are also valves that we use in TAVI world, in mitral position, like SAPIEN or MyValve octacore might be implanted in TAVI or in other positions as well. So regarding the Melody valve, we have to aim for the largest possible dimensions, and we will show you today in the live case why this matters. Regarding the anatomies after the surgery, the conduits or the pulmonary arteries may have different shapes and different problems. They may have type 1, like aneurysmatic dilatation of the RVOT, which is not very good for the pulmonary valve implantation because the landing zone has a very short neck. The most favorable is type 2 with a straight landing zone, as well as type 5. But we have plenty of different anatomies, and every single case is a different case, and we have to take this in account. And to have this ready for the procedure, we do different imaging modalities. So we start with the echocardiogram to see the right ventricle size and function, and also to evaluate the dominant lesion, either it's a stenotic or regurgitation. MRI scan helps us to measure the volumes of the right ventricle and find the indication to perform the procedure, and also to calculate the regurgitation severity. I really like CT scan because I know how to do measurements, and from this I can prepare for the procedure pretty much with the prediction of most of the possible complications. But mainly we look for dimensions, for the sizing. We look for distance to the coronary arteries and also the calcification. So this is a routine scan when we look and we do the measurements at every single level, and this is how the pulmonary artery looks like. We can see the coronaries, and we know from this image that the right coronary is quite far from the conduit, and we should be careful with the left coronary artery in this particular case. Also, when we look for the calcification, what we can see at the lower left corner, there's a white calcium which is semicircular with a very small lumen in the middle of on this conduit, and we cannot really predict how this calcium will behave. Will it fracture? Will it be moved and pushed with a balloon? And but this gives us an idea that it shouldn't be an easy case. Same like here, we have 9-year-old male with a previous surgery and 18 millimeter conduit insertion with this chunk of calcium. And again, we are dealing with young patients, and we are making the plan for them for the first procedure, but also we have to make a plan for them also for the later on. This is a different type of the calcification of the conduit, and this is the calcification to the whole length. And at the top part of this calcification, we can see that there's a healthy pulmonary arteries, and this is the suture line. So when we plan the procedure, we have to cover all this part with a covered stent, and regarding the covered stents, Professor Petrov will give a lecture after my talk. What we are looking after the procedure, we know that in most of the cases, 98% of the cases, we have success after this procedure. We are evaluating the reduction of the gradient, and in ideal case, we shouldn't have any gradients after the valve implantation. Otherwise, it will degenerate quite fast. The valve itself, is a CP stent with a bovine jugular vein, which is suited in the middle of the stent. So this is a bovine jugular vein, which is natural, and where they used to work in a low gradients. Regurgitation and also improvement in the functional capacity for the patient. We know that there are some complications which are very dangerous. The most common is and the most dangerous is a coronary compression. I will show you some images of that. Conduit rupture and valve embolization. I have all of them in my practice. Not proud of this, but that happens for all of us. So coronary compression, before every single case in these conduits, we do a balloon test. We inflate the balloon and do the injection into the coronary. And you can see that there is a gap of the contrast at the left main, just between the catheter and the bifurcation. And we know that if we will deflate the balloon, the blood flow will restore, but if we will miss that, if we will implant the stent, that's it, the patient is dead, because we will block the flow to the coronaries. So if we see the coronary flow, if we do not see any coronary flow after the balloon, we shouldn't proceed, and we should cancel the case. The coronary, the conduit rupture, again, this is the case when the valve was already implanted and was post-dilated with a balloon. And here we have a leak just at the top part of the stent with some contrast going into the pleural space. If we would not treat them, they would die, but we can add additional stent and we can fix the problem. There is a pleural drain inside. There was a massive bleeding into the pleural space, but the patient survived without any residual damage. Stent fractures is very important for the long-term durability of these valves, and these valves are on the market already since 2002. And at the very beginning, it was direct valve implantation, and everybody were happy with the result. But they noticed that the valve deteriorates quite fast. So it was recommended to pre-stent to make a good landing zone for the valve, prevent from this calcium, and after that the valves they last longer. So these are the stent fracture types. Type 1 is when 1 or 2 struts are damaged. Type 2 when several struts are damaged, and type 3 when particles of the stents are disconnected from the stent. And this is one of my of my patients. That's a male, 23 years old. After the Rostello procedure, he had a Melody valve implanted already 5 years ago, and now he came back with increased gradients through the valve. We did the X-ray of the chest, and even there you can already see that there are lots of disconnection of the struts. So we knew that something is wrong with the valve. So the patient went to the cath lab. We did a post-dilation with a balloon. And after the post-dilation, you can see that the stent is moving separately so one part is stable and the other one is attached and already have a laser here. So you can see that the struts already looking outside of the pulmonary artery. There is no a big issue there because we implanted one more stent and then we implanted the Melody valve. However, the chap of 23 years old already have 4 layers of stent and 2 Melody valves. And still we have to make a plan for him in next 10-15 years, what we are going to do with him later on. One of the main issues regarding the long-term results, it's infective endocarditis. And we know that there are some cases, and that's approximately 2% per patient year. That's why we send our patients to dental care every single year. We suggest to have endocarditis prophylactics. And from our side, we try to avoid stent fractures and prepare the landing zone with a very low residual gradients. We have some data regarding that. This is one of the longest studies that we have with percutaneous valves compared with surgical valves. And in 12 years, we have quite a good number with survival rate more than around 90% in 12 years. And also more than 70% of patients, they have the same initial original valve. So the valves last more than 12 years in most of the cases. Take-home messages that the Melody valve is a good alternative to the surgery with a good effect and it's minimal invasive. There are some limitations, which are RVOT anatomy, the size and the shape of the conduit, coronary compression. If coronaries are close, we cannot do the procedure, and also good pre-stenting is a must for having a good result. So we know that endocarditis is an issue for these cases, but we try to prevent this in the future. Thank you.
Thank you very much, Sigitas. Very interesting. You are really expert in this field. I wanted to ask you about the coronary obstruction.
Yeah.
Did you have a case in which you had to implant a chimney, a stent graft, or not?
In most of the cases, if we see the compression, we usually stop the procedure and then we discuss with the surgeons. I have no cases yet in my portfolio that we did the chimney stenting just to prevent the coronaries. That's very rare. In most of the cases, we have coronary compression somewhere in the middle of LAD. There are cases with a compression of left main, but that depends on the anatomy. And also it depends from the calcification. As you saw, I showed that the calcification might be somewhere in one side with a chunk of calcium. And when we deploy the stent, we don't really know how this chunk of calcium will behave. Will it be pushed away, or it's going to be stuck and then the rest of the anatomy will be pushed the other way? So there is no prediction, and I don't think that there is a person who can clearly tell us how this will behave. I think this is the future for AI, but that's not definitely for the next 5 years. We need more time to have the impression.
Okay, thank you. Other questions, comments? Thank you. We release you to go for the live case. Thank you.